Most people think occupational therapy for severe autism is just swinging, playing, and doing crafts, but skilled OT is structured, intentional, and therapeutic. Today, I'm breaking down exactly what real OT looks like when working with a child who has severe autism, limited communication, and major sensory and behavioral challenges. Before any learning can happen, regulation has to happen. A skilled OT begins the session by assessing arousal level, triggers, sensory needs, including vestibular, proprioceptive, tactile, and oral, and the level of dysregulation and risk behaviors. Then the therapist chooses a sensory strategy with clinical reasoning, not random activity, linear vestibular input to decrease fight or flight, heavy work to lower impulsivity, or deep pressure to promote body awareness. This is not just playing. It's modulation designed for a therapeutic outcome. For children with severe autism, tasks like dressing or brushing teeth get broken into micro steps. A skilled OT assesses motor planning, sequencing, grasp strength, tolerance for touch, and cognitive understanding. The therapist then uses backward chaining, hand-over-hand assistance, or visual supports to promote independence. This looks simple from the outside, but every prompt is intentional. Skilled OT doesn't ignore behaviors, we interpret them. For example, a child hitting may be communicating pain or sensory overload. A child bolting may be escaping an unpredictable environment. OTs modify the task, the environment, the sensory load, and the communication supports. This reduces behavior without punishment and supports self-advocacy. Skilled OT means functional, not perfect. We celebrate, I gaze for 2 seconds, sitting for 10 seconds, picking up a toothbrush with assistance. These are massive wins in severe autism therapy. If you want more clear, honest explanations about what skilled OT looks like, subscribe. I break down real-life therapy using evidence-based methods. Working with a nonverbal child requires a completely different clinical approach. Occupational therapy is not speech therapy, but we play a massive role in helping a child communicate through their body, environment, and tools. A dysregulated child cannot communicate. Occupational therapy focuses first on breath pacing, deep pressure input, and rhythmic sensory patterns. Once the nervous system is calmer, communication emerges. Skilled occupational therapy introduces low demand, high success opportunities such as reaching, pointing, pressing a switch, and giving an object. We don't force language. We build cause and effect so that the child learns, my action gets a response. Occupational therapy trials and support are PCES AAC devices, core boards, and gesture systems. We carefully analyze the child's motor skills to match the right system. A child who can isolate a finger might learn to tap icons. A child who uses whole hand movements may start with picture exchanges. The magic happens when we combine motor, sensory, and communication. Some examples are deep pressure, visual choice board, successful request, and finally, the reward. This builds trust and empowerment. Severe autism may include aggression, biting, bolting, or self-injury. Skilled occupational therapy does not punish. We translate behavior into needs, then meet those needs through therapeutic strategies. We assess sensory overload, pain, hunger, transitions, and task difficulty. This determines the clinical reasoning behind the intervention. Skilled occupational therapy creates predictable, safe patterns, clear boundaries, safe movement options, weighted input visual sequences, and low-demand entry tasks. These prevent escalation before it begins. We focus on teaching replacement skills, Instead of hitting, we teach to squeeze a ball. Instead of bolting, we teach to use a transition card. Instead of biting, we teach to use a chew tube. Instead of dropping, we teach to use a first, then board. We teach safer ways to communicate distress. The real work happens outside therapy. Skilled occupational therapy provides coaching so caregivers know when to reduce demands, offer sensory breaks, modify the environment, and use consistent language. ADL training for severe autism is not quick, and it's not simple. Skilled occupational therapy uses structured, step-by-step teaching that honors sensory needs and reduces overwhelm. We break an ADL into micro steps. For example, brushing teeth becomes hold toothbrush, bring to mouth, tolerate bristles, 2-second swipe, rinse, and spit. Each step is taught with reinforcement until mastered. Resistance often comes from sensory aversion. Occupational therapy uses graded tactile play, oral motor warm-ups, predictable routines, and visual timers. We don't force, we prepare the body. Skilled occupational therapy controls the prompting hierarchy. Hand over hand, partial assist, gesture cue, visual cue, and verbal cue, and fades systematically based on responsiveness. Families get repeatable steps so progress continues at home. That's where mastery happens. Too many people misunderstand the purpose of occupational therapy. It is not to fix autism. It's to help children participate more successfully in daily life. For one child, independence might be sitting safely during meals, tolerating hair washing, or using a visual schedule. For another, it might be selecting a preferred activity, completing a chore, or communicating a need. Independence is individual, not universal. We don't teach skills in isolation. We build them through real-life routines, dressing, mealtime, play, and community outings. Every moment is a learning opportunity. Skilled occupational therapy respects stimming, movement, sensory differences, and communication differences. We adapt the world to the child, not the child to the world. The ultimate measure of success is not perfection, not compliance, but engagement, participation, and improved quality of life.